Assalamualaikum. My name is Ardeeni Binti Azman. I am a Year 3 dental student in Uitm Sungai Buloh. Now, I would like to present the case of periodontitis for oral hygiene instruction preclinical project. The case has been provided for this project. For this case, the patient is 43 years old, male and female. She has diabetes mellitus type 2, controlled metformin 500 mg once a day, and latest HbA1c is 6.8%. She never had a periodontal treatment, but the extraction of 3.8 and 4.7 were recently done and went uneventful and healed without complication. She runs her own business and the stress level is 6/10. She is a non-smoker and not aware of any parafunctional habits. First of all, I would like to explain a little bit about the anatomy of periodontal tissue, which is the structures that directly support our teeth in the mouth, which includes the gingiva, the periodontal ligament, the cementum, and also the alveolar bone. The first is the gingiva, or we call it as the gum. The gingiva forms a connection with the tooth and protect the underlying tissue of the tooth attachment. The gingiva has three parts. The first part on the gingiva, which has the smooth surface, which form a curve 1 to 2 mm wide around the neck of the tooth, is known as the marginal or free gingiva. Next is the interdental gingiva. The interdental gingiva is a concave, cold, thin, and not keratinized mucosa that fills the interproximal space between the area of the tooth contact. But for some people where the proximal tooth contact is missing, the interdental gingiva and coal are missing too. And the third is the attached gingiva. It extends from the free gingival groove, which is just below the free gingiva, to the mucogingival junction, where it meets the alveolar mucosa that is tightly bound to the bone. If you can see in this picture, we can differentiate between the attached gingiva with the alveolar mucosa by looking at the changes of the color. For attached gingiva, it appears pinkish color, but for the alveolar mucosa, it appears reddish or shiny. The significance of the attached gingiva is that it protects the periodontium from injury, which caused by the frictional forces encountered during the mastication, or we call it as the chewing. Other than that, it also helps to dissipate the pull on the free gingiva created by the muscles of the adjacent alveolar mucosa. The next structures of the periodontal tissue is the alveolar bone. The alveolar bone, or we call it as the alveolar process of the maxilla and the mandible. The maxilla is the upper jaw and the mandible is the lower jaw. So the alveolar bone are the tooth-dependent structures. They develop with the formation of and during tooth eruption, and also they can atrophy, which is undergo reduction in the bone density for the most part after tooth loss. It is a specialized bone structures that contains alveoli or socket of the teeth and support the teeth. The walls of the sockets are lined with a layer of dense bone called the compact bone, which also forms the buccal and lingual or palatal plates of the jawbone. In between the sockets and the compact bone wall lies the cancellous bone, which that is made up of bony trabeculae. There are many functions of the alveolar bone. The first is it provides the protection to the socket of the teeth. Second, it gives the attachment to the periodontal ligament, which it attaches to the tooth. So it provides support to the root of the teeth on the facial and the palatal or the lingual sides. Lastly, the alveolar bone also helps to absorb the forces placed upon the tooth by disseminating the forces to the underlying tissue. Other than that, the periodontal ligament also play a crucial role as part of the periodontal tissue. The periodontal ligament is a collagenous tissue that surrounds the root of the tooth, attaches the tooth at the cementum to the alveolar bone. The parietal ligament acts to dissipate masticatory forces to the supporting alveolar bone, and its width, height, and the quality determine the tooth mobility. The last structure of the periodontal tissue is the cementum. It is a mineralized tissue overlying the root of the dentin. It does not undergo physiological remodeling, but it continuously deposits throughout life. At the root of the teeth, it appears a pale yellow and softer than the dentin, but it is also resistant to resorption. Before going deeper, let's know about the periodontal health and diseases. First is the healthy gum. Healthy gum tissue is not inflamed and therefore fits snugly and naturally around the teeth. The shape of the gum tissue is typically knife-edge against the tooth and follows a curved line around each tooth. It generally has a firm texture and have a stipple appearance which is a bit like the outside of an orange. Lastly, there is no spontaneous bleeding with the healthy gums. The second one is the periodontal disease. The periodontal disease affect the tissue that both surround and support the teeth. It causes changes to the appearance and the color of the gum. There are two types of the periodontal diseases, which is the gingivitis and periodontitis. For gingivitis, it is a swelling, redness, and bleeding in the part of the gums that surround the teeth, and it is reversible. But for periodontitis, it is a severe gum infection that can lead to tooth loss and other serious health complications, and once it occurs, it is irreversible. How gingivitis and periodontitis occur? There must be something that triggers the disease to occur. In this case, it is a dental plaque or biofilm. So, what is dental plaque or biofilm? Dental plaque is a biofilm or mass of bacteria that grows on the surfaces within the mouth, especially the teeth. It is a sticky, colorless deposit at first, but when it forms tartar or calculus, it becomes brown or pale yellow. The bulk of the microorganisms that form the biofilm are Streptococcus mutans and other anaerobes such as Fusobacterium and Actinobacteria. The consequences of unremoved dental plaque are gingivitis and periodontitis. So, what are the appearance of the gum and what will you have if you are getting this periodontal disease, or we call it as the sign and symptoms? The sign and symptoms patient may have for gingivitis is the gum may appear bright red or purple. You will have gum tenderness, which is pain or discomfort when an affected area is touched. The bleeding from the gums when brushing or flossing, halitosis or bad breath, and also inflamed gums and soft gums. The second one is periodontitis. For periodontitis, you may encounter recurrent gum swelling, receding gums, which make the teeth look longer, extra spaces appearing between the teeth, pus or abscess between the teeth and the gums, bleeding when brushing the teeth or flossing, and loose teeth. The patient's current periodontal condition is based on first intraoral photo. In this photo, there is a mild crowding of lower anterior tooth and calculus deposition on most of the cervical margin of the teeth. Second is based on the full mouth periodontal charting. So in this charting, there is a BOP, which is bleeding on probing. There is a 54% which indicate generalized gingivitis, which shows an active inflammation and poor periodontal health. The second is probing depth. It is a critical periodontal finding that is routinely performed in dental offices and may indicate the presence of the periodontal disease. The probing depth in healthy gingival sulcus normally range from 1 to 3 mm. A depth of greater than 3 mm is a possible causes for concern. For this patient, some teeth have normal, which is 1 to 3 mm, mild periodontitis 4 to 5 mm, and severe periodontitis 6 mm and deeper for the right and left of upper first permanent molar. The third is gingival recession. The negative numbers denote the gingival margin is coronal to the CEJ, which indicates an overgrowth of gingiva, or the tooth is partially erupted. For example, the tooth 2-7 on the distal buccal surface. Meanwhile, the positive numbers denote the recession, which is the gingival level is apical to the CEJ, and the 0 denotes the gingival is at the CEJ. There is no gingival recession. The fourth is clinical attachment loss. It is calculated by adding the probing depth and the gingival recession measurements. For this patient, the result shows periodontitis, which is the data mostly shows the moderate and severe periodontitis. For moderate periodontitis, the value is between 3 to 4 mm, while the severe periodontitis is 5 mm and above. Next is furcation involvement. This indicates the bone loss around the root of multiple rooted tooth. There are two teeth that show grade 2 furcation involvement, which are 1/6 on the buccal surface and 2/6 on the palatal surface. This indicated horizontal attachment loss, which is more than 3 mm. Next is mobility. This will assess the tooth looseness. There are some of teeth shows grade 1, which is light mobility, and grade 2, moderate mobility. And the last one is the plug score. This patient shows 34% indicates moderate oral hygiene. Next is the dental panoramic tomography DPT interpretation. The normal bone level should be about 1 to 2 mm apical to the CJ. In this radiography image, the bone level for most of the teeth appears fairly even with minimal sign of moderate vertical bone loss, which involve the middle third of the root length, particularly at the posterior teeth, for distal of 1/6, mesial of 2/6, distal of 3/5, and distal of 4/6, and also the anterior teeth at the mesial of 1/1. The anterior lower teeth show mild horizontal bone loss, which involves the coronal third of the root length, and some of the upper teeth have undergone moderate horizontal bone loss, which is the tooth 1/1 and 1/2. The rest of the upper anterior teeth show mild horizontal bone loss. There are furcation involvement at the teeth 1/6 and 2/6, and PDR space increase in tooth 2/6 and 3/5, and lastly, there is apical radiolucency of tooth 3/5. The diagnosis for this patient is, this patient have a periodontitis stage 3, generalized grade B with type 2 diabetes as a systemic modifier. And the prognosis for this patient is fair, which is approximately 25% attachment loss or grade 1 furcation inversion. The location and the depth allow proper maintenance with the good patient compliance. Plug score is a cornerstone of maintaining oral health and preventing diseases such as dental caries, gingivitis, and periodontitis. Effective plug control involves the regular removal of dental plaque, a biofilm of bacteria that accumulates on the tooth surface and soft tissues through mechanical and chemical methods. But why is plug control very important? First is because plug control can prevent dental diseases. Dental caries, which is the plaque bacteria, will metabolize dietary sugars, producing acids that demineralize tooth enamel, which leads to the cavities. Removing the plaque can prevent the acid production. For the gingivitis, the plaque accumulation at the gingival margin causes inflammation, redness, and swelling of the gum. Effective plaque control prevents gingivitis and its progression to the periodontitis. And for periodontitis, if left unchecked, plaque can calcify into calculus and cause irreversible damage to the supporting structures of the teeth, leading to the bone loss and tooth mobility. Next, reduction of systemic health risks can be achieved through proper plaque control. Plaque-associated periodontal disease have been linked to systemic conditions such as cardiovascular diseases, diabetes, respiratory infections, and adverse pregnancy outcomes. Controlling plaque reduces the risk of these systemic complications. Next is maintain the aesthetic and functional health. Regular plaque control prevents staining and tartar build-up or calculus build-up, which maintain the natural appearance of the tooth, and it also ensures fresh breath and functional stability of the teeth over the time. A healthy mouth improves overall well-being, confidence, and the ability to eat and speak comfortably, which will enhance the quality of life. Next, proper plaque control can improve healing after dental procedures. Post-treatment healing for procedures such as scaling, root debridement, or periodontal surgery is enhanced when plaque is controlled effectively. Lastly, is reduction in healthcare costs. Preventive care minimizes the needs for costly restorative or surgical treatments. So, what is the consequences of poor plaque control? First, it can cause localized issue. It can lead to dental caries, gingivitis, and halitosis, which is bad breath, which can increase the risk of the tooth sensitivity due to the gum recession. Second is progressive conditions. If the blood is remain undisturbed, the periodontal disease may arise, which later can lead to bone loss, tooth mobility, and eventually tooth loss. The formation of the periodontal abscess or systemic spread of oral infections also may arise. And lastly is systemic impact. The persistent inflammation from the periodontal disease can exacerbate conditions such as diabetes and cardiovascular diseases. There are many types of oral hygiene aids available now in the market that can be used by the patients. The aids are divided into two, which is mechanical and chemical oral hygiene aids. First is mechanical oral hygiene aids. There are tooth brushing aids, which is, for example, manual toothbrushes, which is available in soft, medium, and hard bristle. The most recommended toothbrush is the soft bristle toothbrush, which is to avoid damaging the enamel or causing gum recession. And there is also electric toothbrush, which is more effective than the manual toothbrush in reducing the plaque, especially for individuals with limited dexterity. The second one is interdental cleaning aids. For example, is dental floss. It is used to clean the area between the teeth where the toothbrush bristles cannot reach. And the next example is interdental brush, which is single tufted toothbrush. It is ideally for patients with gingival recession, orthodontic appliances, or dental implants. And the next example is water flosser or oral irrigators. It is a device that uses a jet of water to clean interdental area and along the gum line. It is effective for plaque removal in patients with braces, bridge, or implants. And the last example is wooden or plastic interdental picks. It is suitable for individuals with larger gaps between the teeth. The third is tongue cleaning aids. For example, the tongue scrapers. It is used to remove debris and bacteria from the tongue surface to reduce bad breath and bacterial load in the mouth. And lastly is professional cleaning, which is done by the dentist, which is scaling and polishing, and also root debridement. The next oral hygiene aid is the chemical one. The first is the mouthwash. There are antimicrobial, fluoride, or antiseptic solutions for rinsing the mouth. Antiseptic mouthwash, it contains chlorhexidine or essential oils for reducing bacterial load. And the fluoride mouthwash, which is used to strengthen the enamel and prevent cavities. And the second example is toothpaste, which is there is a fluoridated toothpaste which to strengthen the enamel and prevent caries. The third is spray, and next is irrigators, and the last is varnish. In order to improve oral health, proper oral hygiene instructions in dental cleaning should be given in order to teach the patient the correct techniques to be practiced at home. So, the first technique to be taught is toothbrushing technique. The most recommended toothbrushing technique is modified base technique. Modified base technique. Place the brush along the gum line at a 45-degree angle. Gently brush the surface of each tooth using a short, gentle vibrating action. Brush the outer surfaces of 2 to 3 teeth using a vibrating motion, back and forth and rolling motion. Move the brush to the next group of 2 to 3 teeth and repeat. Repeat the same on the inner surfaces as well. To clean the inside surfaces of the front teeth, tilt the brush vertically and make several gentle up-down strokes using the front of the brush. Scrub the chewing surfaces of the teeth using a short back and forth movement. Lastly, brushing the tongue will remove bacteria and freshen your breath. The second technique is interdental cleaning. First, we can use interdental toothbrush. For interdental toothbrush, gently push an interdental toothbrush that is the right size for your teeth into the space between your teeth. Then, apply gentle pressure with your fingers to the interdental space. And lastly, move back and forth to clean between your teeth and remove the debris.
Proxibrush is a type of interdental brush used for cleaning between teeth and tight spaces where a regular toothbrush cannot reach. It has a small, cone-shaped brush head with soft bristles that can remove plaque, debris, and bacteria from hard-to-reach areas. Proxibrush is a useful tool for improving oral hygiene and preventing gum disease. It can clean difficult-to-reach areas, such as the spaces between lower molars' roots, and adjust its shape to fit concave root areas. It can also clean the area around dental implants.
Next, we can use floss. Insert the floss past the contact point in and out, and seesaw motion to slide the floss near the gum. This also helps to clean the contact point to prevent decay. Once past the contact point and near the gums, push the floss against one tooth to wrap around the tooth side to form a C-shape. Then, gently slide the floss up and down the space between the tooth and gums. You should see your floss disappear underneath the gums. Slide the floss up and down the side of the gums. Do not use a sawing motion when you are near the gums, as this will cut the gums and cause more damage. Next, push the floss against the other side of the adjacent tooth and repeat the same C-shape form and slide the floss up and down the gum. The third method for interdental cleaning, we can use single-tufted toothbrush. The brushing technique is similar to the toothbrushing technique, but this toothbrush should be focusing more on specific areas such as interproximal spaces, furcation area, and any part that is difficult to be reached with a regular toothbrush. The periodontal treatments that can be done for this patient are the non-surgical periodontal treatment, NSPT, and maintenance and supportive therapy. The first is scaling and root debridement. Scaling is the process of removing plaque and hardened calculus from the tooth surfaces above the gingiva. It helps to reduce the inflammation by eliminating the primary causes of the gum disease. It can be performed either through manual instrumentation, ultrasonic scaler, or combination of both. Root debridement is a process to remove the subgingival calculus which is below the gum line. This will create smooth root surfaces which discourage the bacteria reattachment and encourage the reattachment of the gum tissue to the tooth and promote healing process. The second is antimicrobial therapy. This method uses an antimicrobial agent such as chlorhexidine or antibiotics to reduce the bacterial infection in periodontal pocket. For the second therapy, which is the maintenance and supportive therapy, the patient should undergo compliance review after 1 to 2 weeks of the scaling and root debridement, which is SRD. Periodontal review, re-evaluation after 6 to 8 weeks of the SRD, and also periodontal maintenance visit every 3 months. Overall, regular follow-up and patient compliance are essential for successful outcomes. That's all from me. Thank you.